Today's presentation is on both AKI and CKD, so it's going to be quite a heavy one. What I would say is, like normal, if you want to post in the chat and ask questions, that's fine. But I'm not necessarily going to get around to all the questions. So by all means, if you want to bat ideas to each other and answer them, that's great. And I'll take questions as and when we can. I'm going to try and make it quite interactive, so there's going to be some cases that we can look at, and I'm going to be asking for your thoughts before we go on to explaining things. So first off, what I said, so renal medicine's life, let's not overcomplicate it. So the reason I've said that is because renal med generally is something you either love or you just absolutely dread it. And the thing is, the kidneys are one of our sets of vital organs. They are one of the things that really impacts every part of physiology. So you need to at least have some level of understanding for what the kidneys do and what happens when they go wrong. So we're going to go through pretty much a whistle-stop tour of everything kidney related today. So the 6 main objectives we're going to go through. We're going to start with how renal disease can present based on the physiology. So it'll be a quick recap of things you might have covered already in second year, and then relating that more to a clinical basis. We'll define acute kidney injury using the KDIGO definition and talk about some of the risk factors. We'll understand the main types and etiologies of AKI, so going through different ways that you can split that. We'll have a short break, probably at about 7:15, so when we're just over halfway, and then we'll move on to talking about assessing and managing AKI, and then finish off with CKD, which is a bit briefer, and renal replacement therapy. To start off with just some terms, so hopefully these are things that you're aware of from second year already, but just in case you aren't. So we've got oliguria, anuria and polyuria, which are all descriptions of how much someone's urinating. So oliguria is little, anuria is none, so they're in retention, or polyuria is increased urination. Hematuria is blood in the urine. We've then got nephrotic and nephritic syndrome, which some people use this as a way of splitting the different renal pathologies. Personally, it's not the way that I split them, so I'm going to refer to it a little bit in the presentation, but we're not going to touch too heavily. And nephrotic syndrome is where someone's got protein in their urine and then less protein in their blood, which makes sense because if you've got protein coming out, then you're going to have less in the blood left, so hypoalbuminemia. And then also edema, because to do with the contrast in the different pressures between the blood and the extra compartments. So if you've got less protein in the blood, you've got a higher proportion of fluid and more water is going to flow out of the vessels into the other spaces. And then nephritic syndrome, which is again proteinuria, but often that's a less prominent proteinuria, and the key features there are hematuria and hypertension. So if this is something that you prefer to use when you're dividing up your renal pathologies, then Geeky Medics has a really nice summary of that, so I'd recommend going to them. And then hyperkalemia means high potassium and hyponatremia means low sodium. So that's just some definitions. And we'll move on to talking a bit about renal physiology. So again, there are different ways that you can talk about renal physiology. I've broken it down into 4 key things that the kidneys do, and I've tried to make it quite basic because I think it's more important that you understand the key concepts here, so you have things to hang your information on rather than give all the details and then you don't really have anywhere to put them. So first off, the kidneys are a filtration system, so that's both filtering your fluid, your urea, and also your electrolytes. So they do everything from your glucose to your sodium to your potassium. They're also involved in blood cell production, so they produce a hormone called erythropoietin, which is involved in stimulating red blood cell production in the bone marrow. Another key action is that they convert vitamin D to its active form. So vitamin D coming originally from sunlight, it then needs to be activated through the kidneys in order to be used for absorbing calcium from the gut. So if you've not got that vitamin D, you're not going to be absorbing the calcium. And then the final main function is that they're involved in controlling the blood pressure through the renin-angiotensin system, and that's through renin production at the juxtaglomerular cells. So these are things that you probably covered more in phase 1, but it's only through actually knowing those functions that you can talk about how kidney patients present, because it's extremely varied compared to some other organ systems, and that's why we're going back to the building blocks. So the first thing would be, If the kidneys aren't filtering as well as they would normally filter, then you're going to get a raised urea and a raised creatinine. So creatinine is really important in the definitions for both AKI and CKD. You've got fluid overload, which can occur because you're not filtering out enough urine. So if you're anuric and you're retaining, you may get fluid overload. And the electrolyte imbalances, which most commonly we're talking about high potassium and low sodium, but that's not exhaustive. You can have kidney pathologies where you get low potassium, for example. You've got the features of anemia, and you've got your low red cell count if you're not producing erythropoietin, so that's more common in CKD. You've got low calcium and vitamin D, which also has a knock-on effect on the parathyroid glands. So if this isn't something you've looked at before, so you can have primary hyperparathyroidism, which is where the parathyroid glands themselves are just overactive. But secondary is where the reason that the parathyroid glands are overactive is because you've got low calcium, which is commonly due to kidney injury. So you're not absorbing the calcium, and therefore the parathyroid glands are drawing more calcium out from the bone. And then you've got your blood pressure type symptoms. That could be high blood pressure or orthostatic symptoms. So like when you stand up and you get a bit giddy because you're not able to compensate for having stood up and that change in blood pressure. But then you can take this even one step further. And you could say, okay, well, if someone's got high urea, how would that present? So kernicterus is where you're getting neurological symptoms because of the high urea. And that could be one of the reasons why someone might go onto renal replacement therapy. Gout, so when you've got inflammation of a single joint, is due to high uric acid levels. Muscle pain and weakness are features of hyperkalemia. So you could actually have a patient where feeling a bit weak, a bit tremulous is their presenting feature. And it's only through checking the kidney profile that you'll realise that it's because their potassium is high and actually they've had an acute kidney injury. Heart failure can be worsened by kidney pathologies, and you can get pulmonary edema as a knock-on effect from that. So someone might present with breathlessness due to pulmonary edema. They can also have breathlessness due to anemia through the lack of EPO, or breathlessness due to a metabolic acidosis, which we'll come back to later on. This is a lot. I'm just listing things off just to demonstrate how varied the presentations can be. So you can get arrhythmias and cardiac arrest from your high potassium, also arrhythmias due to anemia as well. Osteopenia and osteoporosis due to the hyperparathyroidism. So because your kidneys aren't activating that vitamin D, you can't absorb calcium, you're using calcium from the bone, and therefore your bones are becoming weaker. Tertiary hyperparathyroidism, which is like secondary, but it's gone on for so long that now even if you correct the kidney pathology, the parathyroid glands are still overactive because they've actually hypertrophied. And more commonly in older patients, things like falls and long hospital stays because of those orthostatic symptoms. They're standing up, they're getting giddy, they're falling, they're having a long lie, maybe they're getting rhabdomyolysis and their kidneys are getting worse again, they're getting dehydrated. So this is all a very complex picture. So the reason I've started off with this is because if someone were to say to you, how does acute kidney injury present, or how does chronic renal disease present, it is so varied that it's very difficult to answer that question. So actually going back to the building blocks is really useful. So we're going to now go on to a case history, and this is again just by way of introduction. So we've got a 65-year-old male smoker with diabetes mellitus, hypertension, dyslipidemia and chronic kidney disease, and they've presented with chest pain. The ECG suggests an acute myocardial infarction. He's taken for an urgent coronary angiogram, but 3 days later, he's noticed to have developed an elevated serum creatinine, oliguria, and hyperkalemia. So the fact that he's got the high creatinine and a reduced urine clearance is suggesting acute kidney injury. So what I'd like you to do is post in the chat for any ideas about why the kidneys are in trouble and what has happened. So looking at the history, what are the possibilities for what's going on here? And I'll give you a couple of minutes to post in the chat and then we'll talk it through. Cool, so Nathan said contrast nephropathy. Jana said diabetic nephropathy, definitely possible. Ischemia, yeah, so because we've talked about the MI, so could either be that generally they've had that reduced flow, or it could be a plaque. Yep, acute on chronic, that's a really good term to use as well. I'll give you a minute if there's any other thoughts. Okay, so we've got a really good start there. Lots of possibilities for what could be going on. Some other things you might add to that. So also hospital stay, you might be thinking of dehydration as well, which can precipitate kidney injury, maybe in addition to some of these things we've said. When we talked about the ischemia, that could be because they've had a reduced cardiac output because of the MI, maybe they've gone into heart failure and that's precipitated something. Or maybe it's actually because they are a vasculopath, because they've got this dyslipidemia, they've got the diabetes, maybe they started stenosing their renal arteries. And in addition to that, there's a condition which I must admit I hadn't heard of till I was going through this case, which was called multiple cholesterol emboli syndrome. So this can actually happen when you've had a coronary angiogram. You've actually displaced some of the cholesterol and that has then embolized and gotten stuck in the renal arteries. So that's a possibility as well. Or it could be some of the medications that they're on. So if they've got high blood pressure, they could be on ACE inhibitors. If they've come in with chest pain, maybe before they came to hospital, they tried taking ibuprofen, and that combination can cause an acute kidney injury. So the kinds of things we're thinking here are, how are we going to figure out what's going on? How are we going to assess how stable they are? And then what are we going to do to manage them in the acute phase? So this is the sorts of things we'll be covering in today's presentation. So again, going back a step, AKI is a sudden reduction in kidney function. So that could be from where someone's kidneys were functioning completely fine and now they've had an acute kidney injury. Or someone did use the term acute on chronic. So it could be that their kidney function was already not great, but then they've had a further immediate insult. And then CKD is a gradual reduction in kidney function, which could either be on its own, so it's just started due to an underlying process, or it could be following the AKI. So starting with AKI, because that will be the majority of this presentation, does anyone know any criteria or any ways of classifying AKI? And again, I'll just give you a minute to post in the chat any ideas. So this could be, say, where you've got names of classification systems, or it could just be a way of splitting up pathologies. So yeah, that's what someone's just posted, because you've got pre-renal, renal and post-renal. That's really good. Anything else? Okay. So we'll stick with that for the moment. So that's a good start. Yeah, perfect, Chloe. So yeah, rifle criteria is another one. It's not the one I'm going to be using, but it is good to be aware that rifle exists. Yep, Jana, so creatinine more than 1.5 times the baseline. Yep, and K-digo. Yeah, and based on GFR and urine output. Good. Lots of really strong ideas there. So the one that I'm going to go through is K-digo. Yep, albuminuria. So yeah, that forms part of your nephrotic syndrome as well. Cool. So the K-digo definition. So the second point is one that's already been mentioned in the chat there. So if your creatinine increases to above or equal to 1.5 times the baseline, which is known to have occurred or presumed to have occurred within 7 days, because they might not have necessarily had a blood test 7 days ago, but if you can reasonably believe that it's happened within the past 7 days. The top one, so increase in serum creatinine by above or equal to 26 micromoles per litre within 48 hours. So that's an alternative way of thinking of the creatinine. Or finally, if you've got a significant reduction in your urine volume, so less than 0.5 millilitres per kilogram per hour for 6 hours. So that's the other one. And then classification based on pathophysiology, which was mentioned. So you can have pre-kidney, intrinsic or post-kidney. So that's the way we'll be thinking of it today, but K-digo is really important to know for the exam setting and on the wards, and rifle's another alternate to that. If you actually look on the NICE guidance, they sort of amalgamate all the different definitions together and give a more general appearance, because it's more important to identify generally what an AKI is than necessarily which set of criteria you're using. So starting broadly, for any of the types of AKI that we've mentioned, do you know any risk factors? And there's a lot of them. So anything that might be a risk factor. So yep, diabetes mellitus, certain medications, good. Yep, and specifically ACE inhibitors and NSAIDs. Smoking, yeah, so potentially. I'm not sure if it's on my list or not, but because it's linked to cancers and to other pathologies, dehydration definitely, which links with the vomiting. Transplants, yeah, so that can be people who've had a transplant are at further risk of having further acute kidney injuries. Shock, genetics, gosh, we've got a lot, kidney stones, polycystic kidneys, brilliant. Okay, we've got lots of ideas coming through there. So the list I've got is not exhaustive, so you may well find other ones, but some of the examples. So people over 65 generally are at higher risk, and it's said that that's an independent risk factor, but you could also argue it's linked to a lot of the other causes. So because they're more likely to have vascular disease, they're more likely to have had an AKI in the past, they're more likely to currently have CKD. So it interlinks with a lot of them. The list on BMJ best practice actually says any chronic disease puts you at risk, but the key ones to note are chronic heart failure, liver disease, and diabetes particularly. Anything that restricts your ability to take in fluids. So if you've got a neurological or cognitive impairment, so people say with intellectual disabilities, because they might not be able to control their fluid intake themselves, or particularly people in nursing homes, they may be reliant on others and therefore be dehydrated. So that in itself is a risk factor. Things that cause dilation of the blood vessels, like sepsis, hypovolemia generally, oliguria, which cause and effect, you can argue that one. Nephrotoxic drugs, so we've had some of these have been mentioned already. Contrast agents that we've already mentioned. Cancer and its therapy, so it depends on what combination of cancers and therapies those are including. And also things like HIV and certain toxins. So you covered the vast majority there, which is a good start. So we've already described what AKI is broadly. We've said it's injury before the kidneys, but can anyone give me any examples of what would be a pre-renal AKI, so any causes? Good, yeah. Good. So anything that causes hypovolemia, so any sort of fluid loss, so that could be things like sweating, blood loss, yeah, so sepsis, so that's vasodilation, that's a good cause. Yep, heart failure, yeah, that causes like a relative reduction in blood volume, so therefore that counts, and MI can lead to heart failure. Yep, and then things that specifically lead to reduced perfusion of the kidneys, like renal artery stenosis. Brilliant, okay. So here's just a few examples. So severe dehydration, blood loss, shock, renal artery occlusion, and pharmacological. But you've generally got the picture that there's an insult that's before the kidneys, which is often very systemic, generic things. And pre-renal is pretty commonly considered to be the main kidney injury you'll come across, because in hospital, people who are a bit dry, who've had some blood loss through trauma or surgery, might be on medications. Pre-renal's the really common one that you'll see. So just an example case here. So a 47-year-old man presents with lethargy, nausea and vomiting and diarrhea for 3 days, and he's not been eating or drinking very much. On physical examination, his supine, so lying down blood pressure, is 120/70 and his pulse is 90. But when he stands up, the blood pressure drops to 100/50 and the pulse goes up to 120. So that's suggesting orthostatic symptoms there. Lab studies show that his creatinine has increased to a peak of 289.8 micromoles per litre from a baseline of 53.4, and his random urine sodium is reduced, it's below 10. So this is an example of how a pre-renal AKI could present, because they've had fluid loss through the vomiting and the diarrhea, and they've had inadequate intake because they're not drinking very much. Physically, they are just generally not well, like the fact that their blood pressure is dropping like that, they're clearly very dry, and then you've got that increase in creatinine, which is suggesting the AKI. So this is how I've chosen to show pre-renal AKI. Now, you do not have to think of it this way at all, and it's certainly very arguable because there's a lot of things that you would say come into all of these categories, but I'm just using it as an aide-memoire for if you were asked, say, when you're in an OSCE situation, what are the causes of pre-renal AKI? You can just think, okay, it needs to fall into these categories. So it's volume depletion, loss of effective circulating volume, and renal hypoperfusion. And again, you could certainly shuffle these around a little bit and argue they're in different spaces, but I'm going to go through some of these. So if we start with the first two, so the volume depletion and the loss of effective circulating volume. So volume depletion is things that actually cause a loss of fluid. So things like your GI losses, so your vomiting and diarrhea, skin losses. So burns is actually a big one because you lose a lot of fluid when you've had burns, particularly covering a lot of surface area. And urinary losses, so things like diuretics, and your dehydration and your bleeding. So this diagram is meant to represent your container is the same size, but you've got less in it. So that's volume depletion. Whereas if you compare that to the idea of having a loss of effective circulating volume, the amount of fluid is the same, but your container's gotten wider. So it's the idea that your actual blood volume has not changed, but for some reason there's less blood going round. So some examples would be if someone's in shock and they're vasodilated, their vessels are wider. So therefore, less blood is getting to each part of the body in a given time. So for example, sepsis and anaphylaxis. Congestive heart failure and liver failure. So because you've either got the heart is pumping less blood around, so the amount of blood passing to the organ is reduced, or liver failure to do with your albumin production, those can both be causes of reduced effective circulating volume. So that's another cause of pre-renal AKI, and a lot of you were touching on that as well. And then the third category about the renal hypoperfusion, there's two key examples I want to go through here, but equally bleeding, you can argue, is a cause of renal hypoperfusion in itself. So renal artery stenosis is where for some reason you've got a narrowing of the renal artery, so it is stenosed. So you can see that on this diagram. If you compare it to the normal renal artery, it's clearly narrower. So that could be due to plaque buildup. It could be that congenitally you've got a narrower renal artery. So that's one potential cause. Another cause would be this combination between NSAIDs and ACE inhibitors, and that's been posted in the chat a few times. So I know that a lot of you are probably aware of this, but I'll just go through why it is for anyone who isn't. So the afferent arteriole needs to be broad and the efferent arteriole needs to be narrow for you to have a good blood flow through the glomerulus. The thing that keeps the afferent arteriole open, amongst many other things, is prostaglandins. NSAIDs block prostaglandins. So in doing so, you are less able to dilate the afferent arteriole, so this gets narrower. In contrast, angiotensin II helps to ensure that you've got a narrow efferent arteriole. The ACE inhibitors inhibit that production and therefore mean the efferent arteriole gets broader. So therefore you end up with less blood going in and more blood flowing out, and that means there's less blood in the glomerulus and that causes an AKI. So I'm sure you could go into that in much more depth and explain it better, but if you're going for the basic understanding, that is why the combination of NSAIDs and ACE inhibitors causes AKI. So just to summarise pre-renal AKI, it's where you've got a kidney insult prior to the kidneys, which is namely changes in the circulation, vascular status and hydration. So I'm just going to give you a minute to have a think, and if anyone has any final questions on pre-renal AKI, then I'll do my best to answer them. So feel free to post in the chat now if you've got any questions.